So, welcome everyone to this evening's webinar, the Syphilis Overview in New South Wales, Risk, Testing, Treatment and Support. My name is Jasmine, your RACGP representative for this evening, and we are joined by our presenters, Dr. Kim Collins, Dr. Miriam Grotowski, and our facilitator this evening is Dr. Vani Arjunamani. Before we get started, I'd like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I'd like to introduce you to our speakers for this evening. Dr. Kim Collins is a sexual health physician and works as a staff specialist and BMO in regional publicly founded sexual health clinics on the mid-north coast of New South Wales and in Albury, Wagga and Griffith. She is painfully aware of the realities of time constraints of GPs and is passionate about supportive GPs to do sexual health more efficiently and confidently. Dr. Miriam Grotowski is a senior lecturer in medicine at the University of Newcastle Department of Rural Health based in Tamworth. Miriam graduated from UON with a Bachelor of Medicine in 1989, completed her FRACGP in 1995 and has undertaken a diploma in psychiatry and eating disorders. She completed her Masters in Medical Education through Dundee, UK in 2020. And our GP facilitator this evening is Dr. Vani Arjunamani, who is a full-time clinician for over a decade. She enjoys evidence-based chronic disease management and preventative health care in high-risk populations. And I will hand it over now to Vani to go through our learning objectives.
Thank you, Jasmine. Thank you, Jasmine. So today we're going to utilize a case-based approach to illustrate syphilis testing and management of care, identify at-risk population and clinical presentations that indicate screening for syphilis, and determine the role of partner notification, contact tracing, and support pathways for GPs in managing public health risk of syphilis. And finally, list syphilis clinical tools, resource, and primary care support services in New South Wales. And I will pass it now to Dr. Kim Collins.
Hi, everyone. I think we should advance the screen. Jasmine's doing that for us. So welcome this evening. I know you've probably been really busy all day in your practice and feeling a bit tired, but this is really a fascinating subject. Who'd have thought that towards the end of my career that we'd be seeing the re-emergence of infectious syphilis, and we are seeing that. You know, as students we learned about it. I think I saw one or two cases as a junior doctor, but really it's become quite an issue. So tonight we want to inform you around that and also help you to feel confident managing it. So if we can go to the next slide. So let's speed date syphilis, and I think that's part of what's going on. All of these find a partner apps, you know, what are they called? Grindr,
Tinder.
All gone out of my head. Tinder, thank you. All of those, I think, have made it a lot easier for people to meet partners and to have casual partners. I think that's part of what's going on. So the next slide is just a little quiz. So we're going to try and keep you involved and make this interactive. How many people have seen a syphilis case in the last 12 months? If you've seen more than 5, I certainly have. If you've seen less than 5, if you've not seen any, or if it's not applicable to me currently. So we'll do a poll on this to just get a bit of a flavour. And I think, you know, in general practice, the most likely way that you've seen a positive syphilis test up until the last kind of 5 or 10 years would have been with a dementia screen with an old person. And probably, you know, for most of those situations, either neurosyphilis or just past treated syphilis. That's really changed. So let's have a little look. I think Jasmine's going to have that poll. Okay, so some of you have seen quite a few cases. Excellent. Okay, so this will be very relevant for you, and you'll probably have a greater comfort level around managing syphilis. Some have seen less than 5. about a third of you haven't seen any cases, and for about 10%, it's not applicable to you currently. Okay, very good. So we've certainly got some good brains trust. So let's go to some data around syphilis in New South Wales. We're not going to do a death by PowerPoint. We've really just got this one here to show you the overall picture. So this looks at the rates of infectious syphilis notifications. And to be fair, this is probably an underestimate of true cases. A lot of people don't get that many symptoms with infectious syphilis. So, I think this is probably an underestimate. These are the rates starting at 2014 on the left-hand side of the graph, going through to 2023. So you can see there's been a significant increase both in the males, looking at the yellow line, and in females, looking at the green line underneath. Now you can see the data for the females started at a pretty low rate of 0.7 per 100,000 cases of infectious syphilis. But you can see since 2019, we've been having too many cases. So you can see that in 2023, 5.6 cases per 100,000, and that is above the strategy target, which means we're looking at a situation where we're running into issues around congenital syphilis, and that is a totally preventable public health issue and a failure of public health if that occurs. And I can't see, sorry, just can we go back to that slide, Jasmine, the previous one? I'm just going to move my pictures so that I can see. Yeah, so just again to show you between 2014 and 2023, the rates in women compared to men. Women have gone from 0.7 up to 5.6, and the ratio, instead of 1 to 30, it's like 1 in 8 of the cases are now actually female, and most of those are young women of reproductive age, so under the age of 40, most of them. So the next slide, and these are the cases of congenital syphilis that we've had, and this has led to our to Kerry Chant suggesting that and dictating, or saying that all pregnant women need to be tested during the first trimester and also during the second trimester. No matter whether they think they're at risk or not, because a lot of these women don't know that they're at risk. They don't know that their male partners are potentially having sex with men, and this is one of the big risks for pregnant women. If you've got someone who has been diagnosed with syphilis during pregnancy and has been treated, they are at potentially higher risk of reinfection. And we certainly have cases where women have been reinfected during their pregnancy. So you can see these babies, and again, this is an underrepresentation because there's a lot of fetal loss with congenital syphilis, and there are also high rates of miscarriage. So yeah, something to be aware of. Next slide. So these emerging patient risks and the ones that we're particularly concerned about are women of reproductive age, Aboriginal and Torres Strait Islander people. Men who have sex with men continue to have high rates of infectious syphilis, and we've kind of been seeing that since the kind of mid-2000s, but we're also seeing a lot more cases amongst heterosexual men and women. So these are the important messages. It's rising rapidly, and it's no longer restricted to the classic kind of at-risk groups that it has been up until the last sort of 5 or 10 years. So they have been men who have sex with men, people who inject drugs, people who return from countries where rates of infectious syphilis are higher, and people in remote communities. We're seeing increased syphilis in heterosexuals, and congenital syphilis has re-emerged. So the great pretender is back, and it really is a fascinating disease. As a result of this, we've suggested that all STI testing should include a syphilis test. So if someone comes in and they're concerned about one of their partners, or they're just wanting a screen, if you do a syphilis test, you should also be doing a HIV test. So that's just a routine part now of a screen for anyone who sees themselves as being at risk.
And Kim, I was just going to highlight that I think that's one of the really important take-homes from this, that your STI testing that we're doing routinely in general practice, where we used to think chlamydia and a urine test only, it's now a urine test and at a minimum an HIV and syphilis test. Otherwise, we're going to miss cases. So I think that's one of the really important take-homes from tonight.
Yeah, I agree, Miriam. And if you'd asked me 10 years ago, I would have just said, you know, in a low risk heterosexual, you just do a chlamydia, but that has absolutely shifted. So routinely you do a syphilis and a HIV as well. Okay. So I think the thing that often makes people worried about doing a syphilis test is knowing what to do with the results and what the results mean. And it is complex, but don't let that put you off. Let me show you this little chart. And basically you want, sorry, if you want to just go put those all up. I think in all of this, you want to normalise testing. So this is routine. We just do a syphilis test. It's routine. Don't assume that what you think you know about the person is what they're up to. You can't tell by looking at someone what their sex life is about. So just a basic sexual health history. And again, don't assume you'll make someone feel uncomfortable. I think as a GP, sometimes there are barriers that make you feel a bit, oh, they might think I think they're whatever. It's just like, it's routine, normalised the testing. And basically, because there's been this increased risk in syphilis in particular, we're routinely doing that for everyone. Did you want to discuss that at all, Miriam? Because I know the time pressures of general practice are extreme, and you really just need to be taking a basic sexual health history to know what the results of these tests are likely to mean. So, for example, if they had sex yesterday, doing tests, you know, today are probably not going to be very helpful. So, you know, getting a bit of a picture of what they're concerned about and then doing the appropriate tests.
And I think, yeah, I think the things I'd say about this is that this is routine in New South Wales now to do testing for syphilis twice in the pregnancy, but link it to the other testing you're doing. So we're not adding to your workload. So that first antenatal screen, your syphilis testing is part of it, should have always been, will continue to be. And then you're going to link it to when you're doing often your glucose test in that 26 to 28 weeks. So link it into there if it's not someone who's otherwise at high risk. So I think, you know, put it in with your autofills that you might have in your programs, whether you've got best practice or you've got medical director. Pre-fill your autofill so that it doesn't get forgotten. I think they can be a really useful thing to do. But this should be part of our routine antenatal practice now in New South Wales. This isn't a new thing. It's something that needs to be routinely done and part of your practice. Very important, once again, that we're saying this is for everybody. This isn't me picking and choosing. This is for everybody. And there are some circumstances where we might even test more often, which we're going to get to, but this is the minimum.
Yep, so testing at least twice in pregnancy. And also the other thing that we noticed during our sort of outbreak that we dealt with over the last couple of years is if you've got a woman who's having a miscarriage, she needs to have an antenatal screen, because that antenatal screen will include a syphilis test, and syphilis is one of the relatively more common causes now of a miscarriage. So make sure your women who miscarry have an antenatal screen before they have their next pregnancy. So the complications include stillbirth, fetal loss, preterm birth, neonatal death, low birth weight, and if the babies survive, neurological and other disabilities relating particularly to sight and hearing, cardiovascular issues, and also soft tissue and issues. It's, you know, you give yourself nightmares looking at congenital syphilis pictures. So this is a great tool that ASHM has come up with called Decision Making in Syphilis. And it helps you to accurately diagnose and determine the stage of syphilis. And the things that we find useful are the serology. We also find very useful, particularly for staging, to do a PCR of a lesion. Okay, so if you've got a lesion, we've seen quite a few on tongues and in mouths and anywhere in the anogenital region. Don't forget the anus. The anus is used both by heterosexuals and men who have sex with men as a part of their sexual repertoire. So don't forget to consider having a look at lesions in the anogenital region and in the mouth in particular. It's worthwhile having a history of past treatment, because sometimes, you know, as we know, the serology, some of the tests remain positive for life. And if there is a clear history of past treatment, then that is helpful. And then a clinical assessment, which will include, you know, checking for rashes and other things. So there's, yeah, and what the serology will tell you, this is often the thing that I think puts people off doing the test because they're trying to work out what's going on. Basically, once you're infected with syphilis, the rapid plasma reagent does go up quickly. So you can see that the syphilis serology is on the left, that's the RPR, and then on the y-axis, and on the x-axis is the number of years. So if you get syphilis, your RPR increases quite quickly, as you can see with that red line. If you treat them with the red dot, the RPR tends to drop more quickly than if they're not treated. But all these other tests, so the screening test and then the treponemal specific tests, will actually remain positive for life. So they're not very helpful in terms of gauging whether treatment has been successful or whether the person has been re-exposed. Because the tricky thing with syphilis is you can get it once, we can treat you and cure you, but you can go straight out and get it again. You don't develop any immunity with infection with syphilis. So, and particularly what we noticed in our outbreaks is that there were a pool of people, and getting hold of all of those people and treating them was very difficult, the contact tracing. And we certainly had a couple of handful of cases where people were re-exposed. So you do need to be aware of that. And once someone has had syphilis once, the only way you can know whether they've been re-exposed is with their RPR increases. And that's why we will monitor at 0, 3, 6, and 12 months after someone has been treated for syphilis.
Kim, I was just going to say to that slide that I think it's important to know that as a GP, if you're not treating syphilis all the time and you're not looking at those results all the time, it can be a bit confusing, and you might not be sure about how to interpret the result that's in front of you, and the interpretation is important to get right. But one of the things that I do is, we talk about this a lot, is I phone a friend. I phone someone from a sexual health clinic that's near me. I phone potentially I could phone someone from the sexual health information line. I could look up guidelines such as that form that you said from ASHM. But it is really important not to be scared of doing the test, but to get yourself some resources around you, be they human resources or resources such as these that we're talking about here, that can give a clue as to the interpretation of that result. Really important to have that conversation. You will get more confident as you're doing it more frequently. But for lots of us that work in more broad general practice, where this is one part of our practice, I don't rely on memory to interpret those results. I'm not good enough to do that. I'm going to check in with someone. So here's what I think I'm dealing with. Is that correct? And will that now inform what the next steps are?
Absolutely. So a brain's trust is really valuable. So get to know your local sexual health person, or even the pathologist can be really useful as well. The pathology company that you use, you can ring and speak with the pathologist, and they're often really helpful also. And
some other resources on here. You don't speak to this, Kim, or do you want me to?
I think, would you like to, Miriam? Yes.
Yeah, sure. So the I guess what we've done is put a snapshot of some favourite resources that you might like to look at, or you may already be very familiar with. So for many of us, we might have on our favourites the Australian STI Management Guidelines for Use in Primary Care. Such a good resource, and it gives you really good clues about what to do with many of the STIs that you come across in general practice. And as I said, if lots of you are practicing more broadly in general practice, STIs are part of what you do. So this is a really, really good resource with very specific, up-to-date information. Similarly, the STI HIV testing tool gives some clues about how to ask some of the questions and normalise testing and the tests that might be required. Again, a resource to have on your favourite list. The Young Deadly free website provides resources for young people, elders, parents, youth workers, community leaders and clinicians in remote Aboriginal communities to encourage testing of sexually transmitted infections, and again is a really good resource to be able to give you some advice about what should be happening. And for many of you as GPs, you're used to looking at the community health pathways, and on those community health pathways there should be links to these guidelines that we're talking about, and they may also have information about your local sexual health clinic that is also a valuable resource. So I think it's really important to have some of these already tagged as favourites so that you know where to go to get that information, so you're not feeling at sea. But there are many, many resources, and this will also be information that you can find in that resource guide that will be sent to you at the end of this webinar. Okay,
Very
so we're
good.
now going to move on to some case studies just to illustrate some of what Kim's been informing us about. So giving us that update, thanks Kim, on what's happening in New South Wales and what the landscape is like. And these are some cases that are based on scenarios that are a combination of what's been seen in the community. So let's start with Hannah. So Hannah's 22 years old and she's really excited to see you because she thinks she might be pregnant. You've known her since she was a small child and her parents moved to the area. She's been with her regular male partner for 12 months now. They had a breakup about 6 months ago, now back together, and her last period was a while ago, she's not quite sure when. She also wanted you just to have a check of some sores that she's had on her mouth that don't seem to want to go away. And when you have a look at the sores, this is what you see. Not sure if you can see that clearly, but just on the edge, you might see some shallow ulcers that look like they should be quite painful. And so I just wanted you to think, what further information would you like for Hannah? What do you think might be going on for Hannah? What would happen to your thinking if I said that those sores were not painful? What's your plan? How are you going to get some more information? We might ask Hannah how the sores looked to start off with. I think it's important. She's not really sure when her last period was, so we're not really sure what we're dealing with. But those ulcers look like they could be herpetic, but I'd expect them to be sore. Theoretically, I guess they could be traumatic ulcers or related to some other illness that she has. But the fact they're not painful makes me a little bit worried with a bit of the history that Hannah's given. How far along is she? How are we going to find that out? Are we going to look for whether there's lymph nodes or other sores elsewhere that Hannah may have that may give us a clue about what's going on? We're going to need to do some bloods, aren't we, on Hannah once we work out how far she is, and we're really going to need to be thinking about syphilis and HIV serology. How's that conversation going to go if you've known Hannah since she was a young girl, if you know her family? How comfortably are you going to be doing that conversation? Because I think that's one of the realities of living in a community where you know your patients. But I think it's our job to be comfortable in that space. We're really after helping Hannah get the best care that she can. And part of that is asking some questions in a comfortable way so that Hannah feels comfortable giving you information. What's really going to be important is that we've got some ulcers, we can swab them. We're going to need to see a regular male partner in. Anything else that we should be thinking, Kim?
I think the challenge here is to kind of shift your thinking, because honestly, you would say that that looks like cold sore, looks like herpes.
Herpes,
and you just reassure her. But this young woman had those two areas of shallow ulceration on her left lower lip, her right lower lip, sorry, and we swabbed those for a syphilis PCR. It was positive. So the Treponema pallidum bug, we can use a PCR now, which is great. You need to check with your lab what swab you need to use, but whatever you're usually using for herpes is usually the same that you would do for a Treponema pallidum PCR. And the beauty of this is it gives you absolute certainty that this is primary syphilis. So this is infectious syphilis, it's primary, needs to be treated as soon as possible, and the male partner needs to also be tested and treated.
Yeah, I think that's a really important point. And the fact they weren't painful, I think, is a bit of a clue there. And hopefully one of the things you also take home from this is when we're seeing ulcers, we need to be thinking a bit more broadly now. A lot of those ulcers were herpes. Now they could well be, could it be syphilis? We've got to be thinking, what else could it be?
Yes, absolutely. Because like I said, in the cases that we had quite a few lesions on the tongue and on the lips. So
yeah, we've certainly seen a couple on the tongue in practice as well.
Mm.
All right, so this brings us to a quiz. We're going to involve you again. So Hannah is 12 weeks pregnant. That's what we discovered on our dating scan. So now the question comes, how often are we going to test Hannah for syphilis during this pregnancy? Have we got a poll coming up? Thanks so much, Jasmine. Sorry. So, all right, guys, how often are you going to test her? Are you going to test her once? Did you remember that we've said you've got to test her a minimum of twice as per the New South Wales Ministry of Health? Or is there something different about this case that makes you think we need to do it more often? What's your thinking? If you could just fill out that poll, that'd be great, guys. bit of a loaded question, obviously, but
Well, it is a syphilis webinar.
yeah, I
So
know. Yeah. Fantastic. So by far the majority of you realise that this, because the story that we've just heard from Hannah is puts her in the high risk category, and so she needs to be tested a minimum of 3 times. Kim, so can you talk to that? Why not just the twice?
So in fact, often for these young people, their relationships are very fragile. And I think that what can happen is that there is a risk of reinfection during the pregnancy. So in fact, this woman would be tested at 28 weeks again and at 36 weeks. And at the time of birth, the paediatric team and the obstetric team would know about this. And the Australian Society of Infectious Diseases have guidelines in terms of what tests need to be done. I mean, this is a case where that you would hand over to the ONG and the paediatric people, unless you were doing you know, your own deliveries. So, you know, there are various tests that are done, including an RPR for the baby and the mother at the time of birth, and the placenta is taken for histopathology and for a syphilis PCR, just to confirm that this is not going to be congenital syphilis. Yeah.
Yep, I think that's important, and that's the thing that we're trying to prevent. You know, the reason we're doing the extra testing is to catch these cases so that we are preventing congenital syphilis. And I've been around long enough that there was an outbreak in the west of New South Wales when I reckon I'm talking 20, 25 years ago, where we saw a few cases of congenital syphilis. It's been very quiet for a while now, but we do not want to be seeing cases when it can be prevented. Kim, there's a really good question that someone's asked, and I think if it's all right, we just might, before we go on to the next case, pause now. So someone says, if latent syphilis, if RPR is 1 or undetectable, how do we know that that person has been treated adequately?
Well, it's often difficult. So unless they've got some sort of documentation or very clear memory of the treatment, then we would make sure that we cover them by treating them as latent syphilis. Sometimes we are also in a situation where we don't know how long they might have had the syphilis for, and it would be syphilis of unknown duration, and we similarly would give them 3 doses of the benzathine penicillin. I mean, in principle, it's better off to have a bit too much penicillin than not enough, because syphilis is, you know, pretty unpleasant in its tertiary sort of phases, and you want to make sure you've covered everyone.
Yep. Yeah. Okay, we're going to get to a question that's just come up about the different treatments in a moment, but there is another question that just talks about the fact that sometimes there's a little bit of difference around what's happening in certain in the private obstetrics versus public obstetrics versus private practice. What we're saying in New South Wales is the recommendation, because of the increased rate of syphilis in our population, is that every pregnant woman, doesn't matter who they're seeing, is getting tested at a minimum of twice during their pregnancy. So that's the current recommendation, and that's as far as we can go. So we, you know, most of us in general practice are working in private capacity as well, but we're being recommended to do this testing twice. So I think that that's sort of the guideline that I would follow. All righty. So we might leave Hannah now. Luckily, Hannah and her partner came in and they had good treatment, and we prevented congenital syphilis in Hannah. So that's a nice outcome for Hannah. All right, so Ben's a 35-year-old man who's been coming to your practice for the last few years. He comfortably identifies as gay and man who has sex with men, and he's on PrEP. He has a regular male partner and they have a casual male partner from time to time. He's come to see you because he's got this really annoying rash that he's had for the last 3 weeks. They've been moving house and really busy, so they've been dusting things down, washing walls down, and he really worried that maybe he's become allergic to something, and he wanted to get some cream to settle it down. He noticed that most of the rash is on his torso and his arms, and we've got a picture of this rash coming up. So it's sort of a bit of a diffuse rash, which is pinkish red, small raised lesions, not really coalescing in any particular way, dotted throughout his whole torso. And I think there's another picture This is what's bothering him, though. He's feeling a little bit embarrassed because he's noticed that the rash is on his hands as well. But again, he was really worried that it was one of the cleaning products that he'd been using because they've been moving house. So what's your plan? What are you thinking might be going on for Ben? Does it raise suspicion for you? And if so, what are you going to do about that? Kim, how would you approach a Ben?
Well, I guess it's pathognomic, that palmar rash, and sometimes it will include a similar rash on the soles of the feet, is pretty well pathognomic for secondary syphilis. And I guess this case, he is giving you all the clues. He's a man who has sex with men. He has casual male partners apart from his regular male partner. So he's at risk of syphilis. But I guess the main purpose of this for me is that these rashes can be very variable. Syphilis is a great pretender. I mean, I've seen rashes that have been just like these very fine, sort of bran-like sort of rashes, nothing much to write home about. Seen ones like that, which are a bit more florid. But essentially, if you've got a kind of DD going through your head with someone with a rash, which is, you know, pityriasis rosea, viral exanthema, Epstein-Barr virus, you should be thinking secondary syphilis. And the other thing is seroconversion illness for HIV can give a very similar rash as well. So rashes, again, like ulcers on lips and tongues, are a bit more complicated. You need to be thinking about syphilis as a possible DD.
So one of the things we could do, I guess, is examine him more thoroughly to see whether we've got any other lesions that might give us clues. Maybe there's some painful ulcers that he hadn't realised that he got. That's one of the things I think, you know, that painless ulcers, Miriam,
Yes.
that he may not be aware he has. So I think, you know, that's another clue, but I think this requires an examination. Sorry, Kim, you were going to say something?
Absolutely. And it's worthwhile asking him whether he's had any primary lesions. So has he had a sore in his mouth, around his anus, or on his penis or genitals that was slow to heal, but didn't particularly bother him? I mean, mostly syphilis is painless. I mean, sometimes you can get a painful or tender ulcer, but on the whole, it is painless. Yes, so sometimes there is that clear history, but not always.
Yeah. Yeah, and I guess, as we said, examining the area, he needs a full screen, doesn't he? Full MSN screen.
Correct.
And
so HIV and syphilis bloods, you'd probably already know his hepatitis A, B, and C status because you've got him on PrEP. A throat swab for gonorrhea, a rectal and swab for gonorrhea and chlamydia, and a first ward urine for chlamydia. And get the partner in for screening. That's really important as well.
Yep. And I think the next point is too that really no sex until results are back, so that we can sort of work out where we're up to if that's possible. And what about treating Ben today?
I think it'd be a great idea. The sooner, you know, if you like with those red flags in terms of his risk, in terms of his sexual health history, and his clinical examination, particularly those palmar lesions, you'd treat him today with benzathine penicillin if you had it in your fridge in your practice.
Yeah, and I think that's one of the important points, isn't it? That's one of the, it's a clinical diagnosis along with our bloods, along with our PCRs if they're relevant, but you know, it is also a clinical diagnosis in this context.
Yes.
All righty. I can see Jasmine on there. Okay, good. So we're going on to the last of our cases, and then we're going to come and talk a little bit more specifically about treatment, because we've been alluding to treatment. So don't think that we're ignoring that. We're going to go on and do a bit more. But we're going to look at Harvey. And the thing about Harvey is this is, again, reminding us of different ways that this illness can present. So he's a 68-year-old married man. He's been seeing you for decades, and he comes today with gradual onset of blurred vision over the last few weeks. You send him to the local optometrist if you've got one available, and he calls you to say that Harvey has bilateral uveitis. What's that make you think? What are you wondering what might be happening for Harvey? So Kim, this is not as uncommon a presentation as we would think.
So syphilis can present with neurosyphilis, and ocular presentations are not uncommon. We've had uveitis, we've had optic neuritis. So just be aware of eyes and neurosyphilis. So it can also present as meningitis. You can get hearing difficulties. It's worthwhile considering. And this fella, interestingly, his wife worked for one of the local ophthalmologists, and she had no idea that he'd been having sex with men for most of his adult life. So again, you cannot tell by looking at someone or what you think you know of them, what their risks are. So the treatment for neurosyphilis is a bit more complicated. You need to liaise with your health in the home, and they need 15 days of IV benzoyl penicillin through a Baxter pump. So again, just to be aware that this is the great pretender. It's a multi-system, multi-organ illness, syphilis, and it has all sorts of ways of showing up.
And I guess that's what we're hearing, isn't it? That syphilis is alive and well in our community. It's going to present itself in various ways, and we just need to be thinking about it again. You know, if we're not thinking about syphilis, we're going to miss that rash that could be syphilis. We're going to miss those ulcers that could be syphilis, and we're going to miss the opportunity to test our patients as part of an STI screen. So it should be part of our routine screen. So I think they're really important points to remember. All right, Kim.
And just
a
quick point there is just to give you a bit of an indication. It's not just within general practice. Our EDs as well are seeing a lot of these presentations, and we've had in Wagga, where I work, we've had about 12 presentations of neurosyphilis in the last 12 months, and the bulk of those had presented at least once or twice to our local ED there.
And I think that's relevant for some of these GPs.
We all need to be thinking about it. Yeah.
Because some of them will be working in EDs as well, so it's relevant, you know, for them as well. But yeah, really important to remember that too. Opportunities for intervention, earlier the better, guys. Yep.
Indeed.
All right, Kim, I'm going to hand back over to you around the treatment of syphilis. We've been alluding to it a lot. You can now help us.
Yes. Let's go. So we'll go to the next slide. Thank goodness syphilis remains like completely sensitive to penicillin. Thank goodness, thank goodness. So the treatment depends on the clinical presentation and what stage you decide the person is at. So we've got primary, secondary, and latent. Essentially, primary and secondary are both treated just with a single dose of a single stat dose of benzathine penicillin, which is actually 2 syringes, and we'll go into that because it's confusing otherwise. Secondary syphilis, we also treat just with a single dose, but if they're latent or of unknown duration, then you would treat with 3 lots of benzathine penicillin. So next. This is a little poster we designed up north during our syphilis outbreak over the last couple of years, because what we found was there was a lot of confusion about the treatment because it's not intuitive. You actually have to give 2 syringes. So you can see the picture there. It has to be long-acting benzoyl benzathine penicillin. So it's Bicillin LA. You can actually get it from your doctor's bag. Comes in a box of 10. If you send a patient off to the chemist, they will be given a box of 10, and they will be charged somewhere. We had ranging anywhere from about $250 through to about $450, which is out of the range for a lot of these young, particularly the young people that we were seeing. We use the ventrogluteal site now. You can use the upper outer quadrant, the posterior gluteal, but you need to give it slowly, and you need to give it when it's warm. So it's in the fridge, so warm it up, give it a good, because that will make it a lot less painful, and give it nicely and slowly as a deep intramuscular injection. It's worthwhile making sure that people understand, particularly if they've got lesions or they've got the rash, they've got secondary syphilis, that they may get the Jerich's-Herxheimer reaction, and they can actually feel like absolute crap within about 12 to 24 hours with I describe it as a flu-like illness, aching all over, fevers and sweats. You could get rigors and joint aches. And basically that just means that penicillin is working to get rid of all the billions of spirochetes that are in their system, and they just get this acute sort of terrible, terrible feeling. So we just let people know some Panadol, lots of fluids, and just take it easy for that first 24 hours.
And given that you're doing the 2 injections, it can be kind if there's 2 of you to do it at the
Yes.
same time. Yeah, if you've
If
got
you've,
someone
if
else
you've
in your
got a
practice.
nurse with you or another
Yeah.
doctor,
Yep.
give them both at the same time. We've had situations of people finding that a lot easier to manage than one, then have to saddle up for another one straight afterwards. And what we found is people were getting all sorts of variations of this treatment. We had people who were getting just one injection, and that's easy enough to understand how that would happen. We don't often give two at the same time. We had people who were given two, but a week apart. We had people who were given IV, but short-acting penicillin. So it's just really important to make sure you double-check that you're given the right treatment. And if you're at all concerned, ring your local sexual health clinic or refer them to your local sexual health clinic, and we'll treat them for you. Next. The management, so we go through, if someone's allergic to penicillin, you can certainly, again, refer them to us. We'll often do an oral penicillin challenge because often the allergy to penicillin isn't really a true allergy, and by far and away the best treatment for both for the individual and from a public health point of view is a stat dose of benzathine penicillin. So that's what we aim to do. If someone's truly allergic, then you can give them doxy. If they are pregnant, they really need to have benzathine penicillin. And again, if you're unsure, treat with 3 doses, and they're given weekly for 3 weeks. And it's important that that's 7 days between each of those. Referral of any pregnant woman or neurosyphilis cases as soon as you can. And yeah, just to be aware that it's free for you via your doctor's bag. So it's worthwhile having it in your fridge.
And Kim, can you just talk briefly to the fact that given there was such a surge in the cases of syphilis, there was a shortage of Ben Pen, which may have affected some of the doctors out there with us tonight, but also makes a few doctors a bit concerned, I think, about having treatment availability. So what happened, and what are our options in that situation?
So we're not the only ones seeing this. This is a trend worldwide. We're seeing an increase in infectious syphilis cases and increased demand for benzathine penicillin. And we did have a shortage probably about 18 months ago, but our government managed to get supply from the UK. So we managed it, and there was all that sort of supply chain stuff post-COVID as well that kind of, it played into that. There's not an issue at the moment, and we don't anticipate there to be one in the foreseeable future. So it should not be a problem for you to get long-acting benzathine penicillin.
And certainly in our situation, in our area, when there was a shortage for the GPs, contacting our local sexual health clinic made a difference because they had means and ways of accessing treatment and assisting us with that.
We had stockpiled. And at one point we were prioritising pregnant women. And women of reproductive age, because there was quite a shortage, but thankfully we're through that.
And if you haven't got a link with your sexual health clinic, the sexual health information line is also another really useful resource just to find out what you should do in that circumstance. Okay, so now we're going to talk about contact tracing, because I think one of the things that does tend to concern doctors sometimes is this notion, particularly GPs, contact tracing. Oh, now I've got a case of syphilis. What am I going to do? How am I going to do this contact tracing? It's going to take me ages. It's going to be really onerous. We're here to debunk that myth. So let's get you involved in a quiz again. Last quiz for the night. Have you used the sexual health information line previously in relation to information on contact tracing? And you've got the options of yes or no because you prefer other sites. Maybe you're not aware of what the sexual health information line is, or maybe it's not applicable to you at the moment. So just get you to answer that poll, and we'll just give you a little minute to do that. But Kim, just to reassure the doctors out there, there is plenty of supply of Ben Pen currently. We've got no shortage that I'm aware of.
Correct.
Just wait a little minute for that.
Okay, so 1 in 4. It's interesting.
So that's good. Well,
Okay.
at least a quarter of you knew, so that's fantastic. But more than half of you weren't aware of the website. So another thing you'll go home with tonight is awareness of how invaluable the sexual health information line, which is actually a phone number, is as far as getting some information, which is fantastic. All right, let's have a little look at contact tracing. It's really important. If we don't do contact tracing, we're just going to have a little merry-go-round of syphilis being passed from one person back to another person, back to another person. And the amount of concern this causes, I think, is more than it should be, if that's a fair call, Kim, because I think it's actually quite straightforward. We're going to show you some resources that really make it very easy from general practice land to be able to facilitate contact tracing. It's not all up to us to do it all. But basically, we need to presumptively treat anyone presenting as a contact of syphilis if they've last had sex less than 3 months ago. So Kim, do you want to just quickly just remind people, because you've done this?
Because there's a bit of a window period, similar to HIV, from the time when you're exposed to syphilis to when you either have symptoms or seroconvert, so have a positive test, can be up to 3 months. So if you've got someone who comes in and says, oh, you know, someone told me that I slept with them 3 or 4 weeks ago and they've just let me know that they've got syphilis, you treat those people, because what you don't want to do is be in early stage of exposure and infection and have negative tests, and then that person develops the syphilis down the track and has potentially then spread it to others. So, yes.
Okay,
anyone who's a
great.
contact of syphilis gets treated there and then and tested. And then if their tests are positive, then you'll go on and do their contact tracing.
Alrighty, so like Hannah's case, there could be different types of contact tracing. So we could have had Hannah doing the referral. So for example, Hannah taking responsibility of informing their contacts, or the provider. So someone like us taking control. And the way to do this is you can use different sites, you can talk to your patients. But the thing that I found since really opening the conversation about contact tracing is that many of our patients are very willing and able to do some contact tracing if we help facilitate it. So it's not up to us to do it, which I think is something that worries a few doctors. They feel uncomfortable or awkward, but there's resources out there to make it much easier. So we might just have a look at some of those resources. Now, I actually, in my office, will often open up this website, let them know, and show patients how to go through and make the referral for contact tracing. So we can actually do it in our room together. A patient can bring up their phone and do it together. So you can tell someone, you can SMS someone, you can send an email, and it can be done anonymously through this website. So I think it's really important to show patients resources that are out there in a timely manner. And it really is very quick to do this. I don't know if you do that too, Kim, but I often take patients through this process.
Yeah, and the good thing about this site is there's also some really good hints on how to tell someone.
Yeah.
Sometimes people want to do it face to face, but they don't have the language, and there's some really good tips on that. Bulk of people will do anonymous SMS texting, in my experience, and I haven't had anybody sending an email, so it's mostly SMS texting. And what comes up to the contacts text line is you have been notified as a contact of someone of syphilis, and then there's a link to the Let Them Know website, and they can get more information about where to get tested and things. Yeah.
Yep. So if we go to the next slide, thanks, Jasmine. Sorry. There's different sites that you can go to. So Let Them Know we've just had a look at. There's a Drama Down Under, which is one specifically for men who have sex with men. There's a Better to Know for the Aboriginal patients if they are comfortable with that one. And there's also the New South Wales notification app. So there's different sites that you can show your patients, and they can use the one that they're most comfortable using. And they all do the same thing that you were talking about, Kim. They'll send a message, and it can be sent anonymously through to the contact, advising them of their concern. I'm not sure if our audience have had much experience with this, but it seems to go really well with patients, and it's often done in my rooms when they're doing it. If you're not sure though, and you're still feeling a bit uncomfortable, that sexual health information line is a free call to a 1-800 number, and it's got health profession that are online to give you advice as a clinician from 9 a.m. to 7 p.m. Monday to Friday, which is pretty friendly from a general practice perspective. And they can give you support, they can give you information, they'll talk you through how to use those sites that I've just talked about if you're not sure about it, but also give you some statements and confidence so that you can have a conversation with your patient if you're not really sure what to do. Similarly, they'll be able to assist you with treatment questions and so on should you need to. So I think it is really important that we know about this resource. It is a really invaluable resource for general practice and for anyone who's in primary care wanting to avail themselves some information around sexual health. And so really that's ramped up a lot over the last few years and been a really invaluable resource. So I feel really good. So
and the other thing, Miriam,
Mm.
that's really useful with the sexual health info link is if you've got some complex contact tracing that needs to be done, particularly for HIV and for syphilis and gonorrhea as well, with emerging resistance to gonorrhea. Say, for example, one of the ex-partners, there's been some DV or something, or, you know, like, or the only way they've had contact is through one of the social media platforms like Snapchat or something like that, then they've got special powers that they can sort of unpack some of that more complex contact tracing so that you're not caught up with that yourself.
Yeah, that's great. That's really good. Alrighty, so I guess just summarising this section. So BenPen is the treatment of choice by slow intramuscular injection, and we've got that great resource now from up north that shows us the site. Contact tracing, it's our job to facilitate, not necessarily do, but to facilitate. So I think that might help some of us feel a bit more comfortable getting into that space. Lots of supports out there. And if you're in doubt, ask for help from the Sexual Health Information Link or the local sexual health clinic. Okay. I think we're handing it back to Vani, are we, for some questions?
Yes, there was just this question to confirm that it is not BenPen, which is short acting, it's Bicillin.
Oh, I'm sorry, that's
Yes,
me saying that.
Yeah,
Yes.
just that was a question there as well. So
It's
it's
this is what's
benzathine, though,
confusing.
isn't it? Yeah.
It's benzathine benzyl
Benzyl
penicillin.
penicillin. Yeah,
Correct.
which
That's
sorry.
why it's very confusing. And I think that's, it's just, it has to be the long acting one and it's only given intramuscularly. Yep.
So it's got the LA after it. I think that's one of the important
it's
things.
LA
But it is
Bicillin. The
benzathine,
brand
which
name is
yeah.
LA Bicillin. Yeah.
Bicillin, yeah.
And just to reiterate, it is in the doctor's bag, so it is with us
Correct.
at all times, so it's easy to treat. I mean, easy to access anyway.
Yes.
So I have a couple of questions here about a doctor who was in trouble with public health and APRA because of not completing the syphilis questionnaire that the public health sends out, because the patient never followed up. What's your advice in preventing this from happening and generally in this situation?
Well, look, it can be really tricky, and the thing that made the outbreak that we had so much more difficult was a lot of these people were homeless or had been in and out of jail or had fragile housing, lots of drug use stuff issues as well. So the contact tracing was often very, very difficult. You can only do your best to chase people up and make sure they get treated. We would use at least, the standard thing, if you've got a result that needs to be followed up, is to, text, to email, and then to send a letter to the last address. Where there are still people that we didn't get to treat in our outbreak. So we know there's still other cases out there. So you have to do your best and give the best information you can to the public health unit.
That's what I was about to say, just communicating the efforts that you've made and the challenges that you've had. And that's also where I perhaps get some advice even from SHIL or your sexual health clinic. Here's my scenario. Here's what I've done. Does that sound fair and reasonable? That's what I'd put on the documentation. So I think it's more likely that the issue arose from not enough communication about what had been tried rather than purely because it was difficult, because I hear what Kim's saying in some of these situations, it's just really tricky to meet what is considered to be the gold standard, but you can only do what you can do.
Correct.
Sure.
And in fact, that's what we did in our outbreak. I would ring and speak with and they were mostly our GPs who'd made the diagnoses, and just make sure if they needed any support to find these people, because they were often difficult to find, and to make sure that they had the treatment and they were supported. So yeah.
And I think you mentioned people who have no fixed abodes, like no homes, and they have no contact details. That's what one of the question is being asked now. I have patients in that scenario. How do we help them? How do we contact them, those who are?
Yes, we had difficulty with some. So you just do your best. We did some home visits. We got one young 19-year-old who was pregnant with a second pregnancy, who had infectious syphilis on antenatal bloods. It took us about 6 goes, and we actually eventually ended up going to her home with the benzathine and giving it to her. Yeah.
And the other thing was this was a question that was answered already in the chat, but the sexual health, the SHIELD service, is that open to the general public so you can refer your patients to it?
No, it's more for doctors and healthcare workers to have access to an experienced sexual health nurse who can give some advice and guidance around testing, treating, contact tracing, etc. I don't think it's open to the general practice, to the general public. No. Can you correct me if I'm wrong, Timmy? I think it's really a resource for clinicians.
No, it's absolutely available to the general public, to the general public
line. Oh, it is.
line.
I'm wrong. There you go.
Yep. So often, when you're explaining something to someone who's diagnosed with a partner and they say, how am I going to talk to my partner about this? I will say, well, so you both get the same information at the same time. Why don't you call Sexual Health InfoLink together? And there's no he said, she said, they're really good with that. They just have slightly less hours. So it's 9 a.m. to 5:30 instead of to 7 p.m.
Thanks, Timmy.
Thanks, Tim.
Just one last question I'd like to ask is about the last case, Harvey. So elderly gentleman coming in a community. Do we just do syphilis now for all geriatric patients? I mean, is that to exclude neurosyphilis? I mean, it is part of the dementia screen. So
yes.
I think this was a case where he had specific uveitis. So that was why, uveitis as a symptom, one of the things to consider is syphilis, I think.
Yes, correct.
I think that was the point of Harvey, sorry.
So his presentation around his eyes, and obviously most of us would not be able to make a uveitis diagnosis. You need to see an optometrist or an ophthalmologist. And then once that diagnosis is made, and same if it was papilledema or iritis, then a routine part of that is to do a syphilis screen. Yeah.
So yeah, I guess it's a reminder to be thinking syphilis, Barney, like you were saying, for presentations that are a bit different, but also remembering that syphilis is around in our community now. So not making assumptions about, as you said, Kim, in that case, not making assumptions about who's at risk and who's not. In a case where uveitis could be from syphilis, and testing it will tell us whether it is or not.
Yeah.
And just, I don't know if you have time for this question, it's just within partners, if one's not disclosing to the other and both are your patients, what then? You
work very patiently with the index case to make sure they understand that they've got an obligation to let their partner know, and that also if they don't get treated, they'll just get reinfected.
Yeah. So, I think that's the
they're the two. I mean, most people are very genuinely wanting the best for their sexual partners. Most people.
And you can use the anonymous, the index case can use an anonymous identifier, to send the message. That's the other thing to do. But yep, they're at risk if they don't do something about it.
Great. I think that we're at the end of all the questions. Thank you, ladies.